Good morning, good afternoon, everyone that's joined us today. I'm Christine Stead. I'm the CEO here at ELSO, and am so grateful to be able to introduce a really important effort for the community that we have. And I'm also really looking forward to hearing the discussion today. The leadership on this effort is Peta Alexander and Ryan Barbaro, who have been working diligently on a effort with an amazing team. And you can see the entire team that's been leading this, who you'll hear from today, along with other speakers focusing on their specialty area. But there's an opportunity to think about pediatric adverse event definitions, the outcome definitions. And this group will describe the methodology they've undertaken in great detail. But we think this will benefit our entire community, and look forward to hearing the methodology, hearing the update by each section, and we will save questions for the end. Just a little bit of housekeeping. We will encourage you to ask questions in the Q&A section for this webinar. This is being recorded, and we would love to have the opportunity for everyone to see your questions. Panelists will have an opportunity to answer your questions, but we may decide to answer some at the end so that it can merit a good discussion. And with that, I'd love to introduce Peta and Ryan to get us started. Thank you and welcome.
Thank you so much, Christine, for giving us the time and for introducing us. We are really excited to be here with the ELSO community, who have been just fabulous contributors to this process all along the way, including each one of our international chapters as well. So thank you, thank you, thank you. As Christine said, we're here today to speak with you about ECMO-CENTRAL, which is ECMO core elements needed for trials, regulation, and quality of life. We have been thrilled to work with many of you who are joining us today, and so many others who have dedicated their time and effort, and just with enormous generosity. I do want to introduce our leadership team as well. Matteo Nardo is a pediatric intensivist in Rome. Angie Lortz is a pediatric cardiologist and heart failure specialist in Cincinnati. Pedro Del Nido is a congenital heart surgeon at Boston Children's. Adam Vogel is a pediatric surgeon at Texas Children's. And Nicole Ibrahim is at the FDA and deputy director of CDRH. She is a part of our process because the FDA is generally a part of academic research consortium approaches to defining adverse events. We'll tell you a bit more about that in a few slides, but first, Peta is going to share with you some disclosures.
Thanks so much, and it's really great to be here with you all today. Our first disclosure is actually that ELSO, the organization, has endorsed the ECMO-CENTRAL ARC protocol, so we're all pretty invested in this process. I'm treasurer of the board of directors of ELSO, and Ryan is a member of the board of directors also. We both have ongoing grant funding. I'm trial co-chair of TIDA, a transfusion in ECMO study in children funded by the Department of Defense, and I have some FDA funding looking at another trial design. And Ryan is current co-chair of PediECMO, as well as principal investigator of Ascend, another pediatric ECMO study in respiratory patients. We've got a packed agenda for you today, and we're really looking forward to introducing the team. You can see that we're going to spend a very short time, it's just 10 minutes, talking about the background and methodology of the ARC process before we start to kick through a number of the different definitions that have met consensus through the expert panel process. And we'll introduce each of those as they come. But you can see that we are planning a 10-minute break just before 11 o'clock, and we'll be finished around 12 noon Eastern time.
So the objective of this work was to develop harmonized ECMO adverse event definitions for use in clinical trials, as well as regulatory evaluation. And the impact of this work, we anticipate being standardized definitions that will facilitate the aggregation of data across clinical trials and regulatory device evaluation in order to hopefully improve the outcomes of children. And so our guiding principles really were intentional harmonization with existing definitions, modified where necessary to meet the needs of children receiving ECMO, to make sure that each of those definitions are reproducible, that they're measurable and efficient to use, and if possible, that we avoid treatment as an adverse event definition, though you'll see that wasn't entirely possible in each circumstance.
Ryan and I hadn't actually heard very much about the Academic Research Consortium before we were invited to participate in one of their processes. As it turns out, they're a very established organization with representation on their board by the FDA because they've built definitions that have had such a place in the space of regulatory processes. The best known of the definitions that we've come across from the ARC process are the bleeding definition, which is known as BARC, neurological endpoints for cardiovascular clinical trials, as well as the Valve Academic Research Consortium, VARC, which has had 3 iterations. Each of these have been seated within adult cardiac interventional clinical trials, and the basis of their process is establishing consensus definitions, mainly by harmonizing established definitions of adverse events across clinical trials that just increases the impact of any multi-center study. The first foray outside the adult cardiac interventional space was actually the consensus statement down the bottom, ringed in red, with updated definitions of adverse events for trials and registries of mechanical circulatory support, which was a consensus statement from the Mechanical Circulatory Support Academic Research Consortium. This was mainly relevant to adult populations, and we got invited to join a pediatric equivalent adult academic research consortium process for pediatric VADs. And we were there to represent the ECMO community. And at the time, we recognized that this was a process that the international ECMO community could get behind for pediatric patients, and that we're a separate enough population to undertake our own process. And so that's why we're all here today, to report out the Pediatric ECMO Adverse Events ARC, which is known as ECMO-CENTRAL.
And so the adverse event definition, formulation, and harmonization has really been an attempt to make sure that we're harmonizing with those existing ARC definitions and ELSO definitions, unless there's a substantially better definition in the medical literature. And then absent anything to lean on, we'll use our experts to generate a new definition. Developing the methodology here, we really used the experience that existed within previous ARC MCS chairs, and also talked to other content experts in the space, so statisticians, trialists, librarians, consensus process experts, as well as implementation scientists, to hopefully make sure that as we were thinking about this, that it was designed in a way that we'd be get to the definitions that we felt confident we could stand on. Our stakeholders are quite a few, and I won't read through all of these, but they included regulators like that, such as the FDA from the US, as well as Canada and Japan, members of the Academic Research Consortium, device developers, as well as others who are leaders of ECMO research organizations, funders, biomedical engineers, families and patients who are really generous with their time, as well as many healthcare providers that are listed there.
And the topics that we undertook adverse event definitions for were informed by the adult mechanical circulatory support ARC that had already been published. These included bleeding, neurologic events, acute kidney injury, device malfunction, hemolysis, infection, and vascular access related injury, all of which we'll discuss today, as well as a number of others which were discussed at length and we have achieved consensus definitions for, but we've deemed them less important to share with the entire community in this seminar. And so they'll be available in the manuscript once it's published.
And so this is kind of a slide showing how we've moved across time with this work. And so we really just kicked this work off at the beginning of the new year in January when we presented to the ARC board and were approved for kickoff. Then talked to those stakeholders and leaders that we mentioned to try and make sure that we had developed a strong methodology. And meanwhile, our topic experts who we'll be hearing from today started to generate adverse event definitions. Those definitions were then reviewed in 12 hours of discussion of adverse event definitions. And that may sound a bit tedious, but we had just incredible engagement. Pete, I wonder if you could just maybe show a picture of the team. Everybody really just coming and joining and helping us think about the work that we were doing, and just couldn't be more grateful for that. And it was a lot of fun. In terms of, as we move beyond the adverse event definitions, we took the feedback that we had received in those meetings and tried to edit those, both ourselves as our teams, as well as with others within the group, giving us some written feedback. And then as we did that work, we also just sought community review of our process and definitions from all of our international ELSO chapters, as well as our own PDECMO in terms of a research organization. And along the way, as you'll see on the bottom, they are also sought to intentionally harmonize this process with the pediatric MCS process that was ongoing. We arrived at our first Delphi vote in April, and on that initial vote actually achieved consensus with tremendous participation from everyone, and then used our second vote to assess the feasibility and appropriateness, which again, just in terms of timeliness, we'll hold those results to the manuscript. And then once we're done, we'll continue to work towards ensuring the dissemination of this work. But just thank you, everyone who has just come along with us for this ride on what has felt like at many times quite a breakneck speed, but we've been really just excited about everybody's willingness to come along with us in the work that it's produced.
Completely agree. Can't say enough about the fantastic community engagement and the contributions of people both within and outside the expert panel. Our voting members of the expert panel ended up being more than 100 in number, and that was after we had involved other stakeholders who didn't feel comfortable or weren't in a position to vote on the actual definitions themselves, either because of their regulatory or government agency affiliation, because they were non-clinical, or because they excluded themselves from the vote on the basis of availability for timing. But still more than 100 voting members for the consensus. We were really delighted with the community engagement and collaboration that was achieved.
And so today, Dr. Steve Gorga will kick us off with acute kidney injury. Steve is here with me at the University of Michigan as a tremendous intensivist researcher and educator. Thanks, Steve, for kicking us off.
Thank you guys for having me today. As mentioned, I'm going to talk about acute kidney injury and kind of adverse event definitions. I'm presenting on behalf of just an awesome group of people who helped kind of think and shape what this looks like and what this really is. So as we know, acute kidney injury is super common on ECMO. It's one of the most frequent adverse events in children supported with ECMO, and it's strongly associated with poor outcomes. In a multi-center study of 832 kids, AKI was present in up to 74% of patients and was associated with prolonged duration of ECMO, 152 hours compared to 110 hours in those who didn't have AKI. Also, one really important thing is that up to 93% of cases of AKI are present by 48 hours. And this is robust through a systemic review and meta-analysis where AKI is very frequent and associated with increased odds of hospital mortality. So with that in mind, we set about to kind of understand what the current literature definitions of AKI and adverse events on mechanical circulatory support. And there are really three major ones that I wanted to review, and two of them are really more in depth. Importantly, KidMO used this KDIGO creatinine-based definitions for AKI and ECMO, and we'll go into this a little bit and how we'll advance this definition that was put forth. So first to review are the MCS ARC definitions. They really chose to use that KDIGO framework as the backbone for the definition of AKI. The KDIGO AKI framework was put forth over 10 years ago, and it really harmonized the existing definitions of AKI in the literature, and it combined Rifle and Aiken and some others, and really created this creatinine-based definition, as well as a really important urine output-based definition. Further, the MCS ARC definition includes really important staging criteria, as well as a framework for chronicity. So importantly, the MCS ARC definition, it does use established staging, it does use chronicity, and it can be used for adult and pediatric patients. But on the next slide, we'll show that it does not really include a timing element, and it doesn't really apply well to a neonatal population. And really importantly, all CRRT applications are included. The next definition I want to go over is the ELSO definition. So here we can see that this also has a familiar staging criteria, as well as this really important piece, newly acquired creatinine. So again, That's really important because this kind of gives an idea that this is newly acquired while on ECMO support. And here we can see the staging criteria as well as RRT for all reasons are included. So to review the ELSO criteria, it does include a staging criteria and a timing element, but unfortunately it doesn't include a modern AKI definitions with appropriate creatinine and urine output criteria, and all CRT applications are included. Looking at the broader definitions in the literature, we can really focus on existing definitions and availability to implement them. So we looked into the KDIGO definitions, the podium definitions, as well as some ADKey and updated KDIGO framework on the spectrum from AKI to CKD. And focusing on the neonatal population, we looked at AWAKEN, which really operationalized a neonatal definition based on KDIGO. So here we can see the gold standard that we define AKI by in everybody else when we have these inclusion criteria, which really defines AKI. And then we have creatinine and urine output as well as a timing component, which really gets at the acuity of the injury. From here, we can really see that it breaks down into that severity of staging, and important as validation cohorts have really demonstrated the importance of both a serum creatinine and a urine output staging with their associations with poor outcomes, including length of stay and mortality. Next, podium put forth a renal dysfunction in the context of multiple organ dysfunction. It uses kind of this conditional KDIGO urine output and creatinine framework, and it really doesn't apply a severity. Importantly, the conditions for CRRT here are really important because it includes the initiation for any reason other than toxic ingestion or hyperammonemia, really getting at that CRRT for kidney injury indications. Further, it really uses this fluid balance as evidence that there might be a threshold, but unfortunately, we haven't really defined where that threshold is from podium. One of the great things that podium did was it put forth this idea of what a baseline creatinine definition should be. A baseline creatinine by podium is measured as the lowest measured in the 3 months before admission. And unlike in adults, many children don't have previously measured creatinines, and therefore, when unavailable, this table is really, really helpful. These values are derived from healthy children and have been validated in critically ill pediatric patients. The next two publications I want to quickly review really highlight the importance of outcomes based on patients with early, late, and no recovery of kidney function after AKI. Here, the ADKey 16 group proposed this idea of a timeline definition that suggests AKI exists within a time frame of 7 days, and afterward, we define it as AKD until 90 days and CKD thereafter. In an operationalized definition of this in 2020, 168 adults who received ECMO for greater than 7 days and outcomes up to 10 years were evaluated and really demonstrated that AKD after AKI on ECMO was associated with increased mortality compared to no AKD after AKI. The KDIGO group took this kind of a bit further and put kind of a more of an umbrella term over what acute kidney dysfunction and disease really is, where AKI might be a little bit of a subset of that. But again, this framework really indicates that AKD is a large umbrella and not only includes AKI, but other diseases like glomerulonephritis that don't necessarily meet AKI criteria and resolve within that kind of 90 days or 3 months. So then conceptually, AKD and CKD then exist on a temporal spectrum. This publication really highlights the importance of outcomes of those patients with early, late, and no recovery of kidney function after an AKI event. Finally, last but not least, the neonatal population really needs to be addressed. And this is a big critical gap in existing definitions. Here we can see this familiar table listing serum creatinine and urine output measurements with staging criteria. However, there are really important deviations for neonates that can relate to nephrogenesis through early development. So this was the definition that was used in AWAKEN and really operationalized a modified KDIGO for neonates. First, the urinary output is reported in 24-hour increments as opposed to 6 to 12-hour blocks as it relates to kind of first urine output in neonates. Second, to classify a patient with serum creatinine defined AKI, each measurement was compared to the lowest previous measurement to detect both an absolute and a percentile change from baseline. Comparison with the lowest previous serum creatinine is really necessary because creatinine values normally decline over the first few weeks of life, such that a baseline value is constantly changing. And third, a serum creatinine cutoff of 2.5 rather than 4 was used because for stage 3, since the cutoff of 2.5 in a neonate really yields pretty severe GFR of less than 10, which is equitable to kind of that 4 in adults. So we took this and created a definition, and I split this up into 2 really big things. The first really is I wanted to create that inclusion criteria similar to KDIGO, and then create a staging criteria. So here, this definition includes a reference to acute increase. The baseline will be defined as put forth by podium. So the lowest creatinine measured 90 days prior to admission, and if absent, a baseline will be age and sex index based on published tables. In neonates, that baseline will be taken from Awaken, and so it will be the lowest creatinine in the previous 7 days. The treatment or prevention of complications of kidney injury excludes CRRT for toxins or hyperammonemia, really consistent with that renal dysfunction criteria from podium. Further, it really mitigates classifying CRRT use as a center standard part of the ECMO circuit. And so while survey data of ELSO centers suggest that fewer than 5% of centers routinely incorporate CRRT as part of their ECMO circuit, it is possible that protocolization and increased uptake might happen in the future. And so we wanted to guard against that. This next part really is that similar kind of staging severity as well as the timing staging. So one thing that you can see here is that we really adapted kind of that stage 1, stage 2, and stage 3, and then really brought into that kind of acute kidney disease and chronic kidney disease, recognizing that recovery after an AKI event is really important to understand. One thing that's really notably absent from this definition are other biomarkers. And while we might have a better injury and filtration markers like NGAL, cystatin C, they have yet to be validated in this population as definitional. And so until then, this is really kind of what we used as framework for our definition. When bringing this to the expert panels, we were able to get kind of 91% agreement. And as Peta mentioned, we had over 100 folks responding to this. And so our final definition really didn't change from what we put forth in terms of a proposed definition. And so here, again, you can see we have the inclusion criteria of what AKI is, which really gets at the timing and acuity of the event. And then we're able to break down the severity and duration and endurance of that AKI event.
Steve, thank you so much for that fantastic overview of the definition. Whenever anybody asks us what harmonization means, I quote exactly what you've just reflected in this definition. It's a remarkable effort by the team. Thank you very much for the presentation. And I apologize for my clunkiness of moving slides backwards and forwards. All me, not you. I hope you can stay around for the end, or at least come back at the end for questions. But right now we'll move on to hemolysis, which Francesca Sperotto, one of my friends and colleagues here at Boston Children's Hospital, is going to move forward with describing for us. Francesca trained in Padua, Italy as an intensive care physician for children, and is retraining here as a cardiologist with some additional work. And I'm hoping she'll stay on with us into the future. Francesca, when you're ready, you can take away hemolysis.
Thank you very much, Peta. It's a pleasure to present the hemolysis adverse event definition on behalf of this group that you can see here listed. And I would like to thank again the members for their incredible contribution. So as you all well know, hemolysis is frequent on ECMO, and it has been estimated that a mild form of hemolysis can appear in up to 80% of patients, and a severe form of an hemolysis up to 40%. And it might be device-related, patients-related, or management-related. And as you can see from this slide, it often requires interventions. And the reason why it requires interventions, it's because the association with adverse outcome has been proven by multiple studies. Peta, if you can go to the next slide, please. As you can see in this table that nicely summarize studies in adult or pediatric populations that look at the association between hemolysis and outcome. Hemolysis, especially in its moderate and severe form, has been proven to be associated with impaired renal function, with AKI, with longer duration of CRRT or ECMO, and also with increased mortality. Therefore, it is very important that hemolysis is recognized and that a common definition exists, especially in the setting of common trials. Existing literature definitions are mainly two, and one is the MCS ARC definition that, as you have catch from Peta's slides, is a definition dedicated to adult population on cardiac support, especially on durable beds, with only one table for temporary bed. And the ELSO registry definition that you probably all know, that is has been shaped for all ages on ECMO support for all the indications. In the next slides, you can see the MCS ARC adult definition summarized in this diagram. And you can see that it includes either having a plasma-free hemoglobin more than 20 milligram per deciliter, or an LDH more than 2.5 times upper limit of normality, with a caveat that LDH elevation should not be reported as hemolysis if they are attributable to laboratory errors or hepatic pulmonary dysfunction. Plasma-free hemoglobin increase or LDH increase should happen more than 72 hours post-implant. And hemolysis is then classified in minor hemolysis where no symptoms or signs of hemolysis are present, or major hemolysis when there is either hemoglobinuria, anemia, hyperbilirubinemia, or pump malfunction or abnormal pump parameters. The ELSO registry definitions includes a moderate or a severe form of hemolysis and use the peak plasma-free hemoglobin as a main marker. Specifically, moderate hemolysis is defined as a peak plasma-free hemoglobin between 50 to 100, occurring at least once during the ECMO run and sustained for at least 2 consecutive days. And severe hemolysis is defined as a peak plasma-free hemoglobin more than 100 milligram per deciliter, and similarly occurring at least once during the ECMO run and sustained for at least 2 days. It is also can be also less sustained, but patient meet the criteria if a major component of the circuit need to be changed due to the hemolysis. And for completeness, we also review the literature for other pediatric definitions. And so in particular for other studies that define hemolysis not using the ELSO registry definition. And in this table, you can see a list of studies, the table on the next slide. You can see a list of studies that define hemolysis. And as you can see, plasma-free hemoglobin is widely the marker more used for this definition. With cutoff, they slightly differ one study to another, but there is a good consistency on severe hemolysis with plasma-free hemoglobin more than 100, while the cutoff for moderate hemolysis ranges between 40 to 50 milligram per deciliter. As you can see here also in the column on the top right, no other markers, including LDH, has been used for these definitions. And this is very interesting because we often use other markers, LDH, haptoglobin, in clinical practice, but none of them has been validated, and they are affected by multiple confounders. The last thing that I would like to point out in that table is that the timing of hemolysis assessment is very variable and goes from daily to when clinically indicated or up to once a week. So based on this literature review and existing definitions, we came up with this definition that include a grading of hemolysis in moderate or severe based on the most frequent use cutoffs, in particular moderate hemolysis defining as a peak plasma-free hemoglobin between 50 to 100 milligram per deciliter, and severe hemolysis more than 100 milligram per deciliter. Both has to occur at least once during the ECMO run, and they need to be sustained for at least 24 hours, or they can, patients can meet the criteria also say if they have only one measurement or of moderate or severe hemolysis respectively, but with need of the major circuit component change. We also felt the need to identify a peculiar category of patients that you can see in type 1B and type 2B that has the, that includes the patient that had a run or cardiopulmonary bypass in the previous 72 hours, and this is because the hemolysis can be also partially related to the run of the cardiopulmonary bypass itself. And so this patient will be flagged as type 1B or type 2B. This definition reached 82% of agreement at our open voting. And that's it for the hemolysis. So I'll turn it over to Peta again for further discussion.
Francesca, thank you so much. That was incredible, as we would anticipate. But thank you. Next up, we have Elise Zivic at Charleston, South Carolina, MUSC, who is also a member of the Infection Adverse Topic Group, as well as the steering committee chair for PD ECMO and education. So thank you so much. I really appreciate you joining us today, Elise.
Sure. Thank you guys for having me. I am representing the Infection Adverse Event group, as you can see, and I will say that Dr. Erica O'Neill was the one who headed our group and deserves a lot of the credit for this work, in addition to the other people in our group. Unfortunately, she couldn't be here today, so I am going to do my best to represent her. When we were looking at our pre-existing literature definitions for infection, really there is no existing ELSO definition. ELSO collects a lot of data on infections that occur during ECMO, but there's no specific definitions. What's out there are related more to surgical site infection, bloodstream infection, and then the MCS-ARC has 3 definitions that are generally more related to the support device than to anything else. So we just taking a deeper dive into the existing definitions. We'll start with the MCS-ARC. So there are 3 definitions related to the support device itself. And as you can see, the first 2 really do not apply to an ECMO device. They're more for a VAD. And so we took some components of those definitions to sort of help guide our development of our definitions. And one of the things that is, as you can see in these definitions, is that there are signs of infection, clinical signs of infection, in addition to positive cultures. And so that is one of the things that, one of the pieces that we wanted to take from this pre-existing definition. The MCS definitions do also cover other non-support device related infections that could occur while you are being supported, including infective endocarditis, a bloodstream infection, mediastineitis. And so it gives some definitions and some ideas about how you can define those. There's also an additional definition for patients that develop sepsis while they are on the mechanical support device in this definition, and that's the next slide. And so, as you can see, there's guidance for pediatric patients in particular, if they were to develop sepsis, and how you can define that while they're on the mechanical support. So those were the MCF definitions, and we really tried to model our definitions after that. We also took a look at the definitions from the United Kingdom, really looking at surgical site infections, how they classify surgical site infections. And if you dig into these definitions as well, it is also positive cultures plus clinical signs of infection. And then lastly, we looked at the CDC guidelines for how to define infection. Really, the CDC guidelines on bloodstream infections really just talk about ECMO or ECLS in a very short little paragraph that you can read there that talks about, that gives an idea about timing around if you have a bloodstream infection that's associated with extracorporeal life support, how to think about that in relationship to when the ECMO or the ECLS was initiated. So those were our background definitions. And so for what we came up with, we decided to break things up into three definitions. The first is a peripheral cannulation site infection. The second is central cannulation site infection or mediastinitis. And the third is a bloodstream infection. So starting with the peripheral site cannulation infection, we define this as a positive culture from the skin surrounding the ECMO cannula, where there is clinical evidence of infections such as pain, temperature instability, either fever or hypothermia, drainage, erythema, or leukocytosis. We thought that it should occur after cannulation and within 30 days of ECMO decannulation, so allowing for some time after the support is taken away, and that is consistent with some of the surgical site infections definitions that are in the literature, and saying that the percutaneous site may have drainage and or the surrounding skin can have erythema or inflammation. And then we added grades to it. So either grade 1, which is minimal, local or non-invasive intervention is indicated. Grade 2 is where there are life-threatening consequences and urgent intervention is indicated. And grade 3 is where you can relate the patient's death to this adverse event. Our second is the central site cannulation infection or mediastinitis. So again, similar to the peripheral one, a positive culture from the area around where the cannulation site is, and clinical evidence of infections such as pain, temperature instability, drainage, erythema, or leukocytosis. Again, the same timing must occur within after ECMO cannulation with 30 days of decannulation. We put in a little bit more language in there about deep sternal wound infections, either being from or not involving the components of the ECMO circuit itself. And then similar grading in terms of grade 1 being the minimal amount of intervention is required, and grade 3 being death related to the adverse event. And then lastly, defining a bloodstream infection as a positive blood culture with a new pathogen or no other source identified prior to ECMO. And it must occur at least 48 hours after ECMO initiation, or while on ECMO, or within 24 hours of decannulation. And again, these are graded similarly, grade 1 through grade 3. So those were our three definitions. I think that is all we have. Oh, yes, there's 89% agreement on when voting on this one.
Elise, thank you so much for taking that home for us. There was actually quite a lot of discussion about the infection adverse event, both within the meeting and beyond, with lots of people with important insights to add. So thank you so much for summarizing for us. Next up, we've got Claire Foster. Dr. Foster is joining us from Little Rock, Arkansas, where she is currently almost halfway through an extended training program. She's going to be qualified as a pediatric critical care medicine physician and a developmental pediatrician. So when I met her at the end of last year, I was really excited that we would find work to do together. I'm really pleased that she's joining us today to talk through the neurologic adverse event definition, which she contributed to.
Good morning, everyone. As Peta said, my name is Claire Foster, and I am thrilled to get to speak with you today about the neurological adverse event definitions that were developed by the team on this slide in collaboration with the ECMO-CENTRAL ARC full group. So when we start, this slide illustrates what already exists in the literature on defining neurological adverse events in patients receiving ECMO or mechanical circulatory support. The adult MCS ARC is, as you all know by now, what this whole process is based from, but their definitions are limited to adults and primarily based on cardiac support by VADs. This limits its applicability to our patient population in pediatrics. The existing ELSO definitions for neurological adverse events we'll review in a moment, but they are more limited in their depth than the adult-specific MCS-ARC definitions. We also included the La Rivera and Farhart research studies listed above, as they considered, we considered them to have a well-developed definition of radiologically evident neurological injury that we utilized in our building of our definition. The Cormos paper for the adult MCS-ARC defines 3 types of neurological adverse events. Type 1 is described as overt or acutely symptomatic brain and spinal cord injuries. This includes type 1 ischemic stroke, and also ischemic stroke with hemorrhagic conversion. Will you click forward 2 for me? Thank you.
Sorry, I beg your pardon.
That's okay. There's a lot of boxes that have to move. Stroke not otherwise specified, and then a series of hemorrhagic events, including intracerebral, subarachnoid, and subdural hemorrhages. The MCS-ARC group goes on to describe type 2 as covert injury or asymptomatic brain and spinal cord injury detected by neuroimaging. And finally, type 3 includes transient neurologic dysfunction, such as a TIA or delirium. In addition to the etiology of the adverse events described by the MCS-ARC, they define the impact of the adverse events with regards to severity, recovery, and long-term disability. Using the National Institutes of Health stroke score, the level of dysfunction is classified as mild, moderate, or severe, and a modified Rankin score is used to describe lasting disability versus complete recovery. The existing ELSO neurological adverse events include definitions regarding brain death, as well as clinical and electrographically confirmed seizure activity, and radiologically illustrated adverse events, including diffuse ischemic changes, localized ischemic injury, both intra and extraparenchymal hemorrhage, and intraventricular hemorrhage. The final category is any injury requiring neurosurgical intervention. Both the La Rivera and Farhart studies classified the type, distribution, and burden of the acute infarction and hemorrhage on head CT during pediatric ECMO. This image on this slide represents a series of infarctions patterns that are seen, which we use to help divide our definition categories. In addition to the existing definitions specific to ECMO or mechanical circulatory support, we reviewed a number of other existing definitions of neurological adverse events for broader clinical use. However, these definitions lack widespread adoption in pediatric critical care literature or lack applicability to the full range of pediatric patients receiving ECMO. For example, the pediatric NIH stroke scale is widely adopted and is the National Institute of Neurologic Dysfunction and Stroke endpoint of choice. However, it is limited to patients 2 years of age or older. This excludes a wide spectrum of our pediatric patients, especially our cardiac patients on ECMO. We also reviewed some literature on functional outcomes to mirror the existing MCS-ARC adult outcome definition. The functional outcome measurements included on this slide are the pediatric cerebral performance category and the functional status scale. The pediatric cerebral performance category includes 6 categories of function, from a typically developing normal child, a score of 1, to a child in a coma, a score of 5, or that will eventually progress to brain death, a score of 6. The functional status scale includes 6 domains with potential scores of 1 through 5 in each domain, leading to a potential total score of 6 through 30. Based on this existing information in the literature, our team developed these ECMO-CENTRAL ARC neurological adverse event definitions seen here. It includes 11 distinct types of neurological injury. The first 6 on this slide, A through F, include radiologically evident injury, ischemic stroke, hemorrhages, including intraaxial hemorrhage with and without mass effect, extraaxial hemorrhage, and mixed intra and extraaxial hemorrhage, and finally diffuse ischemic injury. Each of these has a definition listed of associated radiographic findings. Types G and H include electrographic adverse events. These can be supported by electroencephalographic evidence or by a clear clinical event in the absence of EEG in conjunction with neurologist expertise. Type I includes neuropathy, and that is attributable to mechanical complications of ECMO. And our final type K is brain death per institutional policy. Similar to the adult definitions of outcomes after neurologic injury, we utilized a change in PCPC score to describe an endpoint severity grade. This change will be assessed from a retrospective baseline to a PCP score at hospital discharge. A moderate decline is represented by a single point change in PCPC. A severe decline is represented by a 2-point increase in PCPC or a total increase to PCPC greater than 4. And finally, a discharge PCPC of 6 represents a fatal adverse event. With our first round of voting, we were in 92% agreement for the neurological adverse event definition, which was the second highest, I'll add. And then finally, our citations are listed.
No, I hid that slide
on our manuscript, but I do want to thank our full team, especially Dr. Julia Benedetti, who spearheaded our group, and all the other members of our team. We had a great time working together.
Dr. Foster, thank you so much for stepping in for Dr. Benedetti. I agree, the team did a fantastic job of bringing together some complex literature to a definition that the group was clearly happy with, even by the comments that we received with the consensus recommendation agreement. Thank you so much for your work today. I think, given that our team are so superbly keeping us to time, we might actually sneak in 5 minutes of questions now if we can manage that, Christine and the ELSO team. And I wonder whether we can use this time for those of you who are in a position to be able to share your screen on camera. We have been collecting pictures of all of the contributors to the ECMO-CENTRAL community, and we'd really appreciate taking screenshots of everyone who's joined us today. So please, if you're in a position to be able to pop your camera on while you're asking us questions, go right ahead. And Ryan, are you happy to be in charge of taking the screenshots? Good man. Excellent. I'll keep sharing my screen. Have we got, there's Christine back.
Thanks so much, Peta. I'm not sure actually in a webinar that function works so well. I think in the meeting format it does. But I'm happy to say we have over 100 people participating in this, and we will make sure we'll also be tracking how many look at it once it's recorded. But really great participation today from people. And there is, I don't know if you want to field questions now, but Tim Wall has a great question that he shared in the Q&A that might be a good time to field. And any others that people have, if you have one, please send it in the Q&A, and this would be a good time. Thanks.
Absolutely. Thanks, Christine. And I'm sorry for asking for functionality that we weren't organized for. That's my fault. So I'll ask Tim Moll's question, and then we are very keen to give people time for questions, but perhaps we'll just take this question and then we'll move on to the 10 minutes break, and then we'll expect to have time for questions at the end of the next session as well. So Tim's question, thank you so much for being here. I may have missed this in the definition for infection, so I apologize if it was mentioned, but one thing that's always worried me a little about the timing of infections and cultures, I agree. If a patient presents with a supposed sepsis and requires ECLS prior to cultures being drawn, or sepsis is not suspected initially and cultures are drawn after initiation of ECLS, would those then be counted as an infectious complication? Is there a consideration of waiting period for 24 to 48 hours before such cultures would be considered related to ECLS? Does anyone want to take first pass at Tim's question?
So I can answer that. We did address that with the definition of a bloodstream infection. And, you know, I think what we were aiming for there is where we were saying that positive blood cultures with new pathogens or no other source identified before going on to ECMO and must occur greater than 48 hours after ECMO initiation. And of course, while they're on ECMO. And so I think that addresses to some extent the question about children that you think might have a sepsis infection or you know, be septic and do not sorry, I just lost the question in the question and answer, and do not actually have something that is either picked up right before you go on ECMO because samples weren't drawn or something was not obtained. We did talk a lot and debate a lot about culture negative sepsis and how to handle that and how to define that. And so there was a lot of back and forth about that when we were discussing this. And ultimately, I think this was the definitions that we came up with were the best way that everybody could agree on to determine if something was related to ECMO itself versus the child was sick with it beforehand.
So Elise, if I think, so it sounds like you and the group did wrestle with this very question that Tim is asking about, and that in addition, you guys came up with what you thought was best, but recognized that we'll have to see how well this works as things kind of action. Is that right?
Yeah, that's correct. It's a pretty, it's you can go down the rabbit hole of all the different iterations of ways in which you might you know, not be able or could define an infection while you're on ECMO or from ECMO. And I think we talked a lot of back and forth about that exact question that he asked. And ultimately, I think this sort of is the best way that we determined to determine that is that, again, 48 hours after you go on ECMO, a positive blood culture, and that not being what you thought it was before you went on. So you know, you might have had staph in your lungs before you went on and then ended up with a positive blood culture while you're on, you know, probably we would count that as being the infection from the lungs and not necessarily from ECMO itself, if that makes sense.
Thank you. We will save some time for questions at the end of the next session, but we are keen to give everyone just time to stand up, stretch, grab a drink, and see you back here on the hour. So that's 11 o'clock Eastern time for us. And we'll kick on with the rest of the definitions then. Thank you so much for being here. And thank you especially to our speakers already. You've done a fantastic job and I can't believe you stayed to time. Thank you. See you back here in 8 minutes.
Christine, are we just on the panelists right now?
We're broadcasting, and recording, but it's good to just check in. We can certainly chat for hosts and panelists and just remind everyone, as Peta just said, we'll be back at 11.
Perfect. Thank you.
Thank you.
As folks are joining us back from the break, thank you again so much for staying with us. We're really excited to continue on through the second half of this. And Ariane Willems is going to kick us off, who's at in Brussels in Belgium. She is a pediatric cardiac intensivist and researcher of both transfusion medicine and ECMO anticoagulation. We really appreciate the fantastic job she's done leading a quite difficult group. Thank you, Ariane. As we're, again, just giving a couple minutes for folks to join, I do also just want to note, if you have questions as we're going, please don't hesitate to enter those into the chat, and we'll definitely answer those questions in our Q&A section as well. So thank you, everyone, for the questions that have been asked so far.
Hi, everybody from the other side of the ocean. I'm in Brussels and happy to share what we built as the bleeding definition for children on ECMO. I was leading a very incredible group and honored to present this to you today. Next. You all know that bleeding remains a frequent and significant complication in children on ECMO, and both the events but also the amount of blood loss are independently associated with increased risk of death. The causes are first a complex interaction between the patient's blood and foreign surface inducing an inflammatory and hemostatic system response with the coagulopathy. You know that ECMO requires systemic anticoagulation, and sometimes children are put on ECMO after surgery or need an intervention on ECMO, increasing the risk of bleeding. You can characterizing bleeding severity first by the amount of blood that is lost and its physiological consequences, but sometimes bleeding is not that much, and the site of bleeding makes it a severe event. This is an interesting study showing that there's a need for standardization of the definition of bleeding, because every study has its own definition, making comparison very difficult. However, it remains challenging to find an adequate definition in children on ECMO for different reasons. So consequences of bleeding, you have first loss of intravascular volume with loss of volume that you sometimes can measure, leading to hemodynamic compromise, and who can be defined based on blood pressure, heart rate, need of vasoactive agents. But as you know, in ECMO, it's not that easy to define hemodynamic compromise. Secondly, you have also loss of red cells with decreased oxygen delivery and loss of platelets of coagulation factors who can cause a coagulopathy. The second consequence of bleeding that can be used in the definition is based on the first point. First, you can measure and note what the response is to loss of intravascular volume by looking at the fluid and blood products administered to correct intravascular blood volume loss. Or you can also look at the actions that were needed to control the bleeding, first to correct the coagulopathy, or the need to decreasing or stopping or reversing anticoagulations. And finally, in some situations, a surgical intervention is needed to control bleeding. You can also look at the outcomes on the patient's outcomes, such as multiple organ dysfunction syndrome or deaths. Next slide. So all the items that I discussed previously have advantages and disadvantages, And an ideal bleeding score should include first physiological variables that are appropriate for the studied population, in our case ECMO, children in ECMO, should also include specific sites of possible bleeding that are particular to the population or the intervention studied. Ideally, they should be untied to interventions because most of interventions are physician-dependent, subjective, and highly variable. And finally, they should be validated against meaningful clinical outcomes. So after reviewing a lot of papers, we retained those 4 papers to build our definition. The first one is the MCS-ARC definition, but it's a definition in adult with VAT support. We also used the existing ELSO definition, which is a definition that is adapted to our population and also defining bleeding in children. We also took some items of the definition published by Marianne Elise et al., who is based on a more broader population of pediatric critically ill patients. And finally, we also took some items of the paper of Levy et al., who is defining bleeding in adults, but also in children, in cardiac surgery and mechanical support. So our first, the first paper we used is the MCS-ARC definition by Kormos. And interestingly, it is based on severity with a type 1 bleeding, who is a very minor bleeding, going to a type 5, who is a fatal bleeding. And interestingly, in this definition, you have also a type 4 bleeding, who is defining bleeding surrounding the VAT implantation procedure. The definition is considering different aspects of parameters of bleeding, such as the concept of action or non-action to control the bleeding. They are looking at hemoglobin drop and also defining some critical bleeding sites. In the peri-implantation bleeding definition, the definition is taking into account chest tube output, but also amount of red cells transfusion needed to correct volume loss. This definition is also taking into account the location of the bleeding and describe the time relation between of the bleeding, and defining early bleeding related to surgical procedure or need for anticoagulation or secondary coagulation abnormality, but also more another time period, who is following the perioperative period related to anticoagulation and acquired coagulopathy. The second definition that we used to build our definition is the ELSO existing definition of hemorrhage. This definition is based on the need of red blood cells transfusion or whole blood transfusion and the need for intervention. And there's a detailed definition of site-related bleeding, who is seen in ECMO patients, such as peripheral cannulation site bleeding, mediastinal cannulation site bleeding, and surgical site bleeding. The third paper used to build our definition is, as I told you, based on a broader populations of pediatric critically ill children and published by Marianne Ellis and colleagues. It is also a severity-based score, which is validated not only in critically ill children, but also in subpopulations, such as in pediatric cardiac surgery and ECMO patients. It is a consensus-based definition, who is defining clinically relevant bleeding and is looking at outcomes such as worsening MODS, hemodynamic compromise, loss of red cells if it's measurable, and measurement of blood loss, but also defining some site-related bleeding. They didn't put interventions or actions needed to control the bleeding in the definition. And finally, we have a consensus statement published recently by Levy et al. It is a definition in mechanical support population, children and adults, and they are defining different settings, cardiac surgery and the perioperative period, and ECMO and VAT. It's a severity-based ordinal scale with 5 points, and in these definitions, transfusion of blood products or administration of anti-hemostatic agents and changes in coagulation targets are considered in the definition, and they are also defining bleeding based on the site of bleeding. This is the definition in cardiac surgery patient and in perioperative ECMO, and is based on the need of replacement of blood loss by blood products, and also on the quantity of drainage in the chest tube and the need for re-exploration. There's also a definition of bleeding in ECMO outside the perioperative period, and in VAT outside the perioperative period. Next slide. So we based our definition on 5 types, going from no bleeding, based on severity, with a type 0 for no bleeding, going through a type 4 for fatal bleeding. And we retained 3 of the parameters discussed earlier. First, the amount of blood loss or hemoglobin drop. We also considered some critical sites. The second parameter retained to build our definition were the physiological consequences on hemodynamics and oxygen delivery. And finally, in major and severe bleeding, we also retained the response to hemoglobin drop and replacement of intravascular blood volume. So this is our definition. So as I told you, the type 0 is no bleeding or no signs of hemorrhage. The type 1, also called minimal bleeding, is defined as following. You should have measured blood loss of less than 2 milliliters per kilogram per hour, up to 20 milliliters per kilogram per 24 hour, or bloody dressings that should not be changed more than every 6 hours. The second point is clinically insignificant bleeding from endotracheal tube, nasogastric tube, or urinary catheter, but also minor mucosal cutaneous bleeding. And finally, the bleeding should not lead to actions, only to observations, except for the use of local hemostatic agents. The second type or moderate bleeding definitions is defined as follows. You should have an evidence of bleeding associated with any one of the following. First, the quantity need to have moderate bleeding should be between 2 to 5 ml per kilogram per hour for 2 hours or more, with up to 40 milliliters per kilogram per 24 hours period, with a definition, as you see beneath the table, for patients above 50 kilo. You should have a hemoglobin drop less than 3 grams per deciliter over a 12 hours period, without signs of impaired oxygen delivery capacity, defined as a lactate below 3 or falling over the last 12 hours. And third,
Sorry.
it's okay. It's can you go back to type 2?
Go back. Sorry,
Yes.
Ariane.
Yeah, you can also define moderate bleeding by a GI bleeding, pulmonary hemorrhage, mediastinal cannulation site bleeding, or surgical site bleeding that has a physiologic impact but does not meet the criteria of type 3. Next. Yes, type 3 or severe bleeding is defined as evidence of bleeding associated with any 2 of the following. It is blood loss above 5 ml per kilogram per hour for 2 hours or more, of more than 40 ml per kilogram in a 24 hours period, with also a definition in patients above 50 kilogram. You should is defined based on hemodynamic instability that is associated with the bleeding in absence of other causes, such as the start or increase of vasoactive agents and the need of volume administration to maintain pump preload. A severe hemoglobin drop with an absolute value above 3 grams per deciliter within 12 hours, or impaired oxygen delivery capacity evidenced by a lactate above 3 or increasing in 2 consecutive measurements, at least 2 hours apart. Also bleeding that is causing a compartment syndrome in the abdomen or a muscular compartment syndrome. And in this definition, we retained an action to define bleeding that was defined as the administration of more than 40 ml per kilogram of packed red cells in 6 hours. And lastly, fatal bleeding was defined as bleeding that is a cause of death. And we reached 87% agreement during the voting round on this definition.
Ariane, thank you so much. We mentioned that it was a difficult definition to achieve such a thoughtful approach to, but you and your group really brought it home. So thank you so much for both all the work you did on the definition as well as presenting it for us today. I hope you're able to stay around for some questions as they arise after the next 2 presentations. Thank you again. Next up, we've got Dr. Ahmed Stead, who's joining us from St. Louis, Missouri in the USA. We actually tasked Ahmed with doing 4 definitions, which became 7, and asked him to bring all of that together. So he did an absolute yeoman's job of bringing together a number of definitions. But today he's going to present vascular injury for us. Ahmed, thank you so much for everything you've done, and we're looking forward to hearing about cannula-related vascular injury from you today.
Peter and Ryan, thank you so much, and thank you everyone for the kind invitation and for joining the webinar today. So I'm really excited to present the work that we did on the cannula-related injury definitions. And as you can see, I was fortunate enough to work with such an amazing group on these definitions. So if you can move to the next slide. So the currently reported incidence of vascular access-related injury in children seems to be quite low, at less than 1%, but that is limited by the currently available definitions. So as we'll walk through the definitions later on, the ELSO registry definitions are focused mostly on limb vascular injury, The MCS ARC definitions cover both limb and vessel injury, but also provide a grading system that includes the breakdown into major and minor definitions based on the requirement for surgical or endovascular interventions. Other publications have used various definitions, and then there's also the VARC definitions, which are the valve focused working group, adult working group, that also incorporate adverse events related to device dislodgement or embolization or failure of device closure. And next slide, please. Okay, so we'll walk through some of the current definitions. So we'll start with the MCS ARC definitions. So this is the Chromos paper that we've mentioned before. And in these definitions, they cover the adverse events of pseudoaneurysm, AV fistulas, vessel thrombosis or distal embolization, vessel dissection, perforation or rupture, stenosis, cannulation site bleeding, limb ischemia, or vascular access site infection, and then break it down to minor or major complications based on the need for surgical or endovascular interventions. While going to the ELSO registry definitions, if you can press next, thank you. So those cover mostly the limb injuries. So it covers the limb compartment syndrome, fasciotomy, limb amputation, limb ischemia, and tamponade, and don't really cover the other cannulation or cannula-related injury or provide a grading system for it. And then next we have the VARC3 definition. So again, this is the ARC group that work on the interventional valve-related definitions, and they also break it down to major or minor based on the consequence of these adverse events, but they do add the additional valve-related interventional complications as distal embolization or device-related injury. So we wanted to incorporate both approaches of having a group of definitions that cover all the different kinds of complications, but also provide a grading system for those definitions, and also wanted to expand it beyond just the vascular injury. So we expanded it to cannulation and cannula-related injuries too. So the next, great. So our definitions achieved quite a great agreement with 92% agreement on the first round of voting. And then the definitions themselves. So in order to identify the timing of the injury, so we defined our definitions as those injuries that are caused during the process of ECMO cannulation and related to cannula manipulation or movement or decannulation, and not to use these definitions to describe other injuries that happen secondary to vascular access unrelated to ECMO cannulation itself. So the definitions included cardiac or cable injury, so a penetrating injury that is related to vascular access for ECMO that damages the cardiac structures or cava and is associated with a pericardial effusion. A pneumothorax, so a penetrating injury related to vascular access for ECMO that damages the pleural cavity and is associated with a pneumothorax. Limb hypoperfusion, so reduced perfusion to a limb distal to cannulation or vascular injury associated with vascular access for ECMO. Other vascular injuries, so vascular, arterial, or venous injury, including dissection, stenosis, ischemia, rupture, AV fistula, pseudoaneurysm, or retroperitoneal hematoma that are related to ECMO cannulation. And then other cannula-related injuries themselves, so cannula repositioning, post-ECMO cannulation, and additional procedure that is undertaken to reposition the cannula in response to inadequate flow, inadequate respiratory gas exchange, or diagnostic imaging that is not due to dislodgement of a previously adequately positioned cannula. Cannula dislodgement then is at any time during the planned ECMO support, the displacement or dislodgement of an ECMO cannula. And then we also wanted to be able to capture two interventions on blood vessels that haven't really been captured in adverse events before and are really specific to the pediatric population. So vessel ligation, so arterial ligation, the permanent ligation of an RP in relation to ECMO, and venous ligation, the permanent ligation of a vein in relation to ECMO. So then to provide a grading system for these complications, we broke it down to, so next slide. Thank you. So different types, so types from 1 to 5. So type 1 would be a adverse events that does not result in any of the following. So does not impede ECMO flow, does not result in tamponade physiology or hypotension, and is not associated with a higher than type 2 bleeding, as Ariane just showed us in the bleeding definitions, limb or vessel ischemia, or irreversible neurological impairment or death. While type 2 is associated with one of the following, so a pericardial effusion or mediastinal collection leading to impediment of ECMO flow, tamponade physiology, or hypotension, injury to cardiac structures or cava associated with placement of a pericardial drain, or increased compartment pressure within an enclosed limb space, restricting blood flow to the muscles or nerves from ECMO cannulation without tissue necrosis. Type 3 would be those associated with surgical cardiovascular repair to address cardiac or caval injury, increased compartment pressure within an enclosed limb space, restricting blood flow to muscles and nerves from the ECMO cannulation associated with tissue necrosis, or managed by fasciotomy secondary to compartment syndrome. Type 4 is associated with one of the following, so cardiopulmonary arrest for more than 5-minute duration, resulting from pericardial effusion or mediastinal collection, vascular injury or occlusion related to, so that causes reduced perfusion leading to amputation. And then type 5 would be the highest grade, which would be associated with death. So these were the definitions that we came up with in the different grading systems.
Thank you, Ahmed. As Peta said, we really did charge you with quite an enormous task, much larger than I think we recognized that we were asking you for. And you've done, as expected, an incredible job of leading quite a wonderful team across all of the diverse asks. Next up, and also challenging, Alvaro. Rojas Pena is here at the University of Michigan and leads Dr. Bartlett's lab in ECMO, and is also a surgeon and a member of our Department of Surgery here. He will be talking to us about mechanical adverse events, and then we will shift over to questions. So again, please, if you have questions, do share them in the chat. Alvaro, thank you so much.
Hello, everybody. Peta and Ryan, thanks for the invitation. Peter and Christine, thanks for putting it all together. My team discussed the device failure and the definitions for adverse events. So next slide. Let's just start with a little bit of background. I think everybody here knows that the ECMO system is not just a device, it's the use of many components such as the cannula, tubing, connectors, pump, the membrane oxygenator, the heat exchanger, and the console. All of these are interconnected into a close arrangement to ensure one thing, ensure blood flow efficiently into each of them. Next. So any failure of one or multiple components can cause multiple complications in our patients, such as sudden loss of blood flow, thrombosis, leaks from blood, plasma, water, air embolism, hemolysis, or even death. So the problems are from death to small inadequate ECMO support for small periods of time. Recently, the Food and Drug Administration report about the manufacture and use of facility devices and reported that ECMO mechanical failures are associated with serious complications. The most reported patient-related adverse event were hemodynamic decompensation and death, and the most reported failure of the components of the ECMO system were the pump and the membrane oxygenator. Next. So for the main references, I think everybody's familiar with the MCS-AR consensus. They recommended that any definition of device malfunction must be captured sufficiently granular data to be meaningful to clinicians and engineers so they can assess the root of the problem and develop corrective strategies to resolve the identified issues. Next one. We also look at the historical definitions that was published by the ELSO or by ELSO. So we know that also include most of the common components, pump, cannulas, oxygenators, and heat exchanger. However, the definition required a revision that was aligned to the new ECMO paradigm and use of integrated system. We need to also identify proper documentation of the impact of the failure to patients and include all the components of the ECMO system. So we need to create a framework for future clinical trials on ECMO. Next one. So the most important thing is that the current definitions of ELSO do not incorporate the ECMO system components and the potential degree of failure of each of them. Next. So what was presented to the group for voting was the ECMO device malfunction is defined into 4 hierarchical reasons for device exchange according to the degree of failure, relentlessness, and abruptness. Next. The type 1 is a structural failure, is a loss of separation of blood and air from compromised structural integrity of the device, and is likely attributable to a given circuit component. Next. And we have type 2, functional failure. It's a complete and abrupt loss of mechanical operation, but it may be more difficult to attribute to a given circuit component. Next. And we have the device dysfunction, is the reduced performance of the components device dedicated task at optimal parameters. The attribution to a given circuit component is variable. Next. Or is a device replacement, is a replacement of the device without identified failure, but this does not rule out dysfunction or could still result in patient consequences. We also define patient consequences. Can you go back into severity, and I will report that table at the end of the presentation. Next. Okay, so the ECMO components that we identified are listed here. So we have the blood pump or the whole system replaced due to a blood pump issue. The membrane lung or the whole system replaced to a membrane lung. The cannula or whole system replaced due to a cannula. And just keep in mind that the cannula dysfunction sometimes do not require replacement, but it requires the demonstration of visual evidence of thrombus within the cannula, leading to an intervention for thrombi removal. The tubing or the whole system replaced due to tubing issues, so it's similar to the cannula. The dysfunction can include replacement, exchange of a segment, or cutout of the segment. Tubing or connectors or whole system replaced due to tubing connector failure. The heat exchanger or whole system replaced due to a heat exchanger. The ECMO console or whole system replaced due to ECMO consoles problems, and the whole system replaced due to an identified dysfunction that is not able to be localized to a specific ECMO component. Next. Okay, so we have here, in regards to integrity, we find that is anything that impacts the integrity of the device separation of blood and air leading to the blood leak, air entrainment or embolus, and managed with replacement or separation from ECMO or resulting in patient death. Next. Failure is divided in 2 categories. You have mechanical operation, which is the failure or presumed failure of normal mechanical operation and managed with replacement or separation from ECMO or resulting in patient death. Electrical operation is failure or presumed failure of normal operation of the blood pump, some membrane lungs, heat exchanger of the ECMO console or the whole system when the ECMO console is integrated. Next. Device dysfunction is determined by failure of the device to perform its dedicated task at optimal parameters, managed with replacement or separation from ECMO or resulting in patient death. And type 4 is a device replacement without evidence of dysfunction. Is replaced of a device without document failure of the device. Most often is because a specific protocol regarding longevity of use or sometimes transport of patients in different systems. Next. For the patient consequences, we identify 5 grades. The first grade is transient, asymptomatic, or mild symptoms, clinical or diagnostic observation only. Grade 2 is the maintenance of patient vital signs that require an escalation in non-extracorporeal life support. Grade 3 is hypotension or hypoxemia despite medical interventions. Grade 4 is cardiopulmonary arrest requiring CPR, and grade 5 is death. Next. And finally, we develop a device failure probability scale. It goes from -3 to 7. And the main point here is that we ask questions that prove or not if the device was the cause. The first question is, did the adverse event improve after the component was exchanged? Did the adverse event reappear after failing component was exchanged? Are there alternative causes other than the specific ECMO component that could on their own have caused the failure? And was there objective evidence for failure observed with the exchange component? So the score goes, if it's more than 5 or more, is definitive related to that device component. Probable between 2 and 4, and not likely or doubtful is less than 2. With these definitions, we got a 90% agreement from the 98% pool.
Alvaro, thank you so much for taking us through the definition that I know was quite a lot of effort on your behalf and on behalf of your team. Thank you so much. I hope you're able to stay around for questions. Ryan and I have just got a couple of minutes of next step summaries, and then we can kick straight into question time. So thank you again.
Thank you, Peter, Ryan, and team.
Ryan, do you want to run us through next steps?
Absolutely. Thanks, Peta. So yeah, so I think in terms of next steps, our hope is that once this work is completed and published, that it results in the incorporation of adverse event definitions into clinical trial protocols and registries, and that also that it helps to enable us to do some epidemiologic studies of adverse events within modern ECMO, and furthermore, and this comes back to our impact, is that potentially enables the secondary analyses using aggregated data across clinical trials with shared definitions. And of course, what we've presented today has involved intentionally many of our adult colleagues, and we're hopeful that, and they seem interested in kicking off an equivalent adult process for those adult patients who are supported on ECMO as well. And so our hope has been that by working together with them, that they're kind of pre-setting the stage for harmonization with that work as well. And so, yeah, without further ado, love to open things up to questions and just kind of kick things off. I'm happy. One of the questions that we did get in the break was a question from Jonathan Lilly, just about, do we think that some of the consensus that we have achieved has really been driven potentially by maybe a homogeneous population? Sorry, Jonathan, these are not exactly your words, I'm paraphrasing. And I would say that, obviously that's a really important question, and it gets at one of the things that we were focusing on doing in the design of this study. And specifically, we sought to design into our team diversity. And we mean this across quite a number of various different domains. One of the domains is just an experience. And so we did see that most of our colleagues were quite experienced, but we definitely had folks such as Francesca, as well as Claire, who presented here today with us, who are emerging experts in their field, as well as we, of course, had many others who had been with us for many decades of experience as well. And so we also sought to achieve diversity in terms of this nation or state where folks are from, are practicing medicine. And there, more than 40% of our participants were from outside of the U.S. We recognize that means that quite a few of our participants were from the U.S., and we will continue to strive to do better there. But we definitely feel like we're working to achieve there. And then in terms of just the breadth of practice is just probably too much to list, but we have every kind of intensivist and surgeon that we could identify, as well as many other areas around delivery of care of ECMO support, from pharmacists to
social workers, psychologists, perfusion, bedside nurses, We had librarians, data scientists. We really did go out of our way to see if we could get representation from everyone. Sorry, I didn't mean to take over your voice there.
We've been completing each other's sentences for a while. It's perfect.
It's been 6 months. I meant to say right before the slide was taken down, so I might actually go back to sharing just for a second. Thank you, Alex and team, for being so proactive. I did just want to share the SurveyMonkey QR code. For anyone who'd prefer to send us comments offline, anonymously, in any way that you like, please use the QR code. You can send us anything you like there. But we're much more interested and invested in having you guys ask us questions and put us on the spot, including any of our panel of experts that we've brought along today. I did just want to reiterate what Ryan was running through as he was talking, though, the importance of the diversity and representation that we achieved in the expert panel, but also the amount of discussion that went into these adverse event definitions prior to the point we took them to the vote. And this was something that we actually anticipated taking these to the vote right before ELSO, which would have been a full 6 weeks earlier than we did. And both our regulatory colleagues at the FDA and other experienced people who'd been through ARC processes in the past said to us, just stop. You will never get consensus if you take them the way they are now. Find every loud voice, find every quiet hole, and talk to people individually and in small groups to make sure that you've actually got something that the community can agree on. And so we took the advice. It was a little bit difficult for us at the time, I'm not going to lie, and paused for a full 6 weeks and took the opportunity to meet with people at ELSO, meet with people on the different ELSO chapter international webinars, and follow up with anybody who had comments to make sure that what we came to the group with were definitions that we believed were representative of what people could get behind. So we did double up in every way we could think of, John, and everybody else who is concerned about the diversity represented by the expert panel and the voting group. And we hope that we've achieved something that can be meaningful wherever you practice and whatever your practice looks like. Now, Christine and Peter and any of you who'd like to jump back on camera to be a part of discussion, I'd very much appreciate. Sorry to put everyone on the spot. And now I'm gonna keep an eye on the Q&A. The next question that did come up during the break as well that we haven't addressed was somebody was curious about the effects of eCPR on hemolysis and whether that should be a separate consideration. I know Francesca was thinking about this. I'm not sure whether Francesca's been called away clinically. You there? Oh. Are you happy to take first pass at that one?
Sure. Thank you for bringing up eCPR. We all know that it's, very challenging managing eCPR patients because they are sicker and the outcome is generally worse. So I think the eCPR patients are at higher risk of AKI renal dysfunction. So there might be a particular interaction and association between higher degree with the multi-organ dysfunction and higher degree of hemolysis, but the definition should apply as it is. It's like probably more likely that they are going to have severe hemolysis than other patients. I don't know if Peta or Ryan have anything else to add.
No, I agree with that as well. And this is actually, hemolysis is particularly challenging because what we're interested with the definition is both a reflection on the etiology and whether or not the circuit components, the ECMO support itself is contributing, but also the patient consequences of having severe hemolysis. And so it didn't make sense to us to modulate the definition of moderate or severe hemolysis, which is obviously has patient consequences, we believe, in order to account for the different etiologies except for cardiopulmonary bypass, because it does, we do recognize that cardiopulmonary bypass can independently be associated with impressive hemolysis that is associated with a different set of kit of technology, not the circuit components that would be attempting to adjudicate adverse event association with for ECMO. Thank you. Christine or Peter, you've been here since the beginning of this process as well, and I'm really interested if you've got any specific questions, particularly anything that might relate more to ELSO and how ELSO might consider approaching the different definitions that might be coming through.
Peter, why don't you start, since you've been here for only 26 years, which doesn't really count as getting started, but
He doesn't
you
look a
have
day
point of
over
view.
30. I don't know how he's done
I know,
it.
it's shocking.
No, I think this is a fantastic project. And I think, since Ryan has done so much with the registry and knows it so well, the data points that we can incorporate, I think it's going to be a very smooth process. And for those things which we don't, when we do, or if we do, we'll be set up for that. And just having such a large group, being able to go over them and actually come up with a very defined and consensus of what these are, I think is going to really help us in the long run. So I don't really have a lot of questions. I just want to thank your group for all that you're doing.
Peter, thanks for those kind words. It's always been a privilege working with you along the years. Thanks a lot. Christine, anything to add?
Oh, just that I also think where the community is going and the quality of research that we expect, especially from all of you that have been part of leading this work, I'm really excited about the future of what we'll see in research in particular for ECMO patients, pediatric neonates, and also adults. I think you're setting a nice precedence here too for the adult space, and I really appreciate the methodology. Thank you.
And Matteo, I wonder, just as one of our co-leads, if there's anything that, as you've kind of been listening, if you're able to kind of reinforce or add to that kind of high level conversation we're having right now.
Thanks, Ryan. I think first of all, you and Peter, of course, and all the whole team did a great job on this. We really had the need to have harmonization on the definition of adverse events. One of the things that I really found very cool is to see today the results of the voting, very high results. And this is something that we should interpret very carefully, because it is the process that was used during this let's say period to tailor the definitions step by step according to the suggestion that we have. And probably this is why we got such a big agreement so far. And this is, according to me, something that will be of an extraordinary power for the future, especially when we are going to use the definition on future trials.
Thank you, Matteo. Appreciate that. And thank you for all of the guidance and work that you with along the way. I really appreciate all of the meetings that you've joined us at, quite unsociable hours that we have occasionally scheduled them for. If you happen to be living in Europe, thank you. There's a couple questions that are coming into the chat. The first one, I wonder is if the questioner is able to clarify a bit. Pete, I don't know if you quite understood it, but I'll just read it out loud. It's from Jope Drop. It says, "Thank you for your great work towards standardization of definitions in ECMO patients. Can you elaborate on how you will make sure that not only these definitions will be used, but also how to make sure that definitions will be interpreted equally?" I guess what I'll say is, if hopefully this is near the mark, as kind of the way I interpret that question is, how do we make sure that the rubber is meeting the road well? And so I think that comes to one of what Peta and I mentioned as next steps, which is really to actually assess the use of these questions and understand if there are barriers in terms of their implementation. Along those same lines, we also were interested in what users thought before they've had a chance to kind of put these in practice. And we did ask some follow-up questions in terms of what folks thought was the feasibility of using these definitions, as well as the appropriateness of these definitions. And we did hear, absent their use, reassurance that it seemed to be able to be used well, but we definitely are going to have to start to apply these and see how they apply.
We recognize that the definitions are for some of them particularly quite complex and may not actually be immediately translatable into a registry-based data collection approach. And that's one of the reasons why this is certainly an ELSO involved process, but it's not, ELSO isn't obliged to adopt any of the definitions that have come through, because these weren't designed as registry-based definitions. But we have started integrating the definitions into the ongoing clinical trials in the pediatric ECMO space, specifically the TADA trial, which I'm co-trial chair for, and we've actually incorporated the adverse events into our serious adverse event definitions, which we adjudicated as part of the trial. In addition, as we were with stakeholders, we did hear that there was interest in common data element inclusions with some of the National Institutes of Health and equivalent funding agencies in the UK specifically. And so we're continuing to move that process forward in the background. So we hope that part of the implementation of these definitions will be supported by the institutions that actually endorse and fund important research in the space moving forward. But the FDA being involved in this process from the start, and indeed kind of kicking us off with the ARC process, will also incorporate implementation of these data definitions as expectations when devices are being adjudicated and for clearance in their process. So we hope that we've done a little bit more for implementation of these definitions into practice than is often the case when an academic project is undertaken. And kudos to Dr. Barbaro for that one. He's had it in mind since the beginning.
I wonder also, just kind of shifting gears a little bit, Alvaro, if you're in a position maybe to share with us a little bit about, what your kind of experience in the lab is and what that's looked like and how that kind of helped to inform some of the work. Because one of the reasons why we asked you to help us with this is obviously a lot of what you do in your day-to-day life is kind of looking at and testing and developing these projects in kind of the more defined space of a translational lab, as opposed to maybe the less defined space that we find ourselves in at the patient's bedside.
In the lab, we're asked to test multiple components or new generation of components, primarily with the aim to demonstrate non-inferiority. Once we demonstrate that, then the component is considered safe. And FDA takes that for the approval of lungs and some of the cannulas now, and even pumps. So sometimes clinical data is not needed. But when we go in the lab, we use the ISO regulations and we test at the extreme the circumstances. And we have seen what can happen to those devices. For example, integrity, it got dropped and then suddenly you have a crack and you have water leak or blood leak or sometimes plasma leak. So there are many things that you have to assess for each one of those components. Sometimes the sterilization process affects your cannulas. Sometimes the sterilization process affects the membrane of some lungs. So, and then transport. So humidity affects a lot of things. So you have to consider all of those issues. So what we did is we tried to follow the ISO guidelines. We went to the FDA recommendations when they want to do a 510K for devices, and we plug it into the definitions. Again, looking for everything that can happen from electrical. Again, now we have lungs that have electrical components, and maybe if they fail, it's not a jeopardy to a patient, but still is a failure of the device. So those are the things that we have to keep in mind, and that's why the definitions evolve a little bit.
Alvaro, thank you so much. And as Ryan said, we have benefited enormously from your experience in Dr. Bartlett's lab and Dr. Bartlett's endorsement from afar. One of the things that you've reflected back to a couple of times when you were answering Ryan's question is the ISO standards. And they were something that I was aware of. Every one of our devices has an ISO something written on it somewhere. But what you're talking about is the International Standards Organization, ISO preclinical testing standards, which are actually pretty well established, even for the types of devices that we're talking about incorporating to ECMO circuits. This, I'm not sure that we didn't say it out loud this time, but actually this ARC process is the first ARC process that actually incorporated representation from the ISO board. Ajit Yonganathan joined us as one of your team putting together the mechanical adverse events definitions. And the combination it really did change the way we thought about mechanical adverse events. Alvaro, is there anything else you wanted to speak to around that, or otherwise I'll move on to answering hemolysis?
No, briefly, Peta, on that clarification on ISO. ISO tested, and it goes into thrombogenicity, for example, or white blood cell consumption. And this is the extreme. So yes, they're doing it in animal studies and so on, and they don't want us, I mean, we cannot really incorporate full of that because it will be very different or extreme to what we'll see in the clinical side, but at least the concept is there in the definitions. Yeah.
Yeah. No, thank you so much. We've really valued working with you together on this and all of our expert panel, actually. Just looking back to the questions in the chat, Ashish Ankola, who's one of our past senior fellows from Boston, now keeping up the track in Texas Children's Hospital, asked the specific question about timing of hemolysis and how we chose the 72-hour mark for the post-cardiopulmonary bypass definition. It's a great question. And actually, if we looked in the literature about how long you'd expect cardiopulmonary bypass to affect hemolysis, we kind of found that out to about 48 hours, didn't we, Francesca? But when we started harmonizing definitions with existing definitions in the literature, the previous MCS ARC definition included this 72-hour delineation, and the current ongoing process for PEDS-VAD also includes that 72-hour delineator to suggest that actually it's very challenging to assign hemolysis as an adverse event for the ECMO components if we're looking instead in that 72-hour period after cardiopulmonary bypass. So we fell into line and harmonized with the existing definitions while expecting them to harmonize to the existing ELSO definitions of the two different cutoffs for moderate and severe hemolysis, because so much data has come out of the ELSO registry around that hemolysis differentiation. And indeed, the PED MCS ARC have taken on board the ELSO definition of hemolysis at that 550 instead of the previous definition that they would have otherwise matched to, which was the adult MCS ARC. So it's kind of a lot of blurring lines in all directions so that we hopefully achieve some sort of uniform grayscale at the end. But thank you for a fantastic question. I'm aware that we're coming up to the top of the hour, and I wanted to take the opportunity to thank all of our collaborators, contributors, and everybody who's made comments along the way. Thank you. And special thank you today for the ELSO team, who we obviously work very closely with. So we know how much we appreciate you even more than other people might recognize. But I'd love to leave the last couple of words to you if you've got some, Christine.
Well, thank you. That was a very well run and informative webinar, and I really appreciated also the practical questions that arose, like, can we see this one? Can we see this in normal definitions and things like that? So thank you also, Peta and Ryan, for your guidance on what that might look like going forward. We will have this webinar, which is being recorded, but we expect it to be available on our website. We're hoping for 48 hours or something close to that. So as soon as possible, and we'll make sure we do a social media, push on it to remind people so that you can see this and refer to it wherever you would like. Thank you so much, everybody. We really appreciate your time and energy and enthusiasm on this. Thank you.
Thank you so much, all.
Thank you.
I appreciate it.